So I told Anna Granovich, this is her presentation last week was a really tough act to follow. I can guarantee you will not feel as relaxed after my presentation, but I do hope that you'll be intrigued about the role of emotions in chronic pain. So thank you for having me here today to chat about this topic. Nothing to disclose, objectives. By the end of this presentation, you'll be able to define emotion regulation and describe a model of emotion regulation in chronic pain. You'll be able to identify areas of emotion regulation difficulties that are common in chronic pain, and you will be able to understand the longitudinal relationship, so understanding how emotion regulation actually relates to pain outcomes. So a little bit of background. I think everyone here is very familiar with the fact that chronic pain is very prevalent. It occurs in about 1/3 of children and adults worldwide. In about 10% of the population, we see severe disabling chronic pain. But in general, pain is associated with impairment in numerous domains, including functional impairment, vocational, social, psychological. So folks here who work with patients who have pain, are well aware that pain can touch many areas of a person's life. In terms of mental health disorders are very common in chronic pain. So here you can see some ranges and some prevalence rates. We see rates of depression, anxiety, and PTSD that are much higher than the average population. So one thing that's really important to understand about pain is that pain has both sensory and affective components. So the experience of pain is not just defined by the nociception or the physiological change in the body, but it is also defined by the affective context that it occurs in. So an analogy that I give to patients all the time is this is sort of the difference between stubbing your toe on the worst day of your life, where, if it's me, maybe there's some tears, maybe there's some cursing, maybe it feels like a terrible injustice and it hurts a lot, versus stubbing your toe, the same injury on the best day of your life, maybe it's something you can make a joke about, can kind of laugh off, probably not as painful. So to understand pain, we have to understand the emotional context that it's happening in. For this reason, a tremendous amount of research has gone into understanding how people with pain cope with those difficult emotional aspects of pain. We can call this pain coping. So very hot topic in pain psychology for a long time. A few examples of how people might respond to the distress of pain are with pain catastrophizing. So this is experiencing pain and then having very negative cognitions about that pain. So things like, this pain will never go away. This pain has ruined my life. I'll never be able to be the partner or the parent that I once was. People feeling that pain and assuming or worrying that it must be something much worse. So this must be cancer. There must be something the doctors are missing. Again, if you work with people who have pain, you've heard this and you've seen this. So pain catastrophizing is one way people can respond to the distress of pain. Kind of on the other end of the spectrum, we have chronic pain acceptance, which is the process of accepting that pain is something in your life, in your body, and the act of going on with your usual activities despite that pain. And again, if you work with people with pain, you also see this end of the spectrum. Another one is fear of movement. So some people respond to the distress of pain by avoiding movement for fear that pain's going to get worse, that they won't be able to tolerate it. So this is another way that people cope with pain. So hundreds, if not thousands, of studies in the pain psychology literature have shown that greater pain catastrophizing, more fear of movement, and less chronic pain acceptance are associated with worse pain intensity, worse disability, and worse mental health symptoms. So the way that people are coping with pain is defining or influencing strongly their outcomes. For this reason, pain coping is a common target of pain psychology intervention, and a lot of our common pain psychology treatments have been developed specifically with pain coping in mind. So for example, cognitive behavioral therapy for pain, among other things, addresses pain catastrophizing by teaching people to recognize those pain catastrophizing thoughts and generate alternative thoughts that are more neutral or realistic. So rather than pain is ruining my life, pain is getting in the way right now and it's not pleasant, but I'm working with my team to come up with a plan and I'm learning to get back to some things I care about. So things like that. CBT Might also address fear of movement by helping people develop sort of hierarchies of activity, of physical activity, and help them slowly face that fear and get back into being more physically active, for example. Other treatments like acceptance and commitment therapy really hone in on that acceptance piece and helping people learn strategies to increase the acceptance of pain. This is all very important, and understanding how people cope with pain has been really instrumental to understanding how we can treat people who have pain and help them live better lives. I'm interested in a construct that is a bit more broader than pain coping. So if we kind of zoom out specifically from how people respond to the emotional challenges of living with pain, we get a construct called emotion regulation. And emotion regulation refers to how we're managing emotions in our lives in general. So to be human is to experience a constant stream of affective or emotional information. We're always in some affective state, and we are often engaging in strategies to either change or maintain how we feel. So this isn't a new concept for anybody here because we all do this all the time. So everyone here is familiar with having an emotion that isn't so comfortable and trying to do things about that emotion to feel less of it, or possibly to feel more of it in the case of feeling more positive emotion. So emotion regulation is a general construct that relates to how people are managing their emotional experiences, generally speaking. So surprisingly, not a lot of research in the pain world has looked at emotion regulation. So this research has really honed in on how people respond to pain, but we don't know a lot about how people with pain are responding to other emotions in their life, like stressors at work or problems in their interpersonal relationships or experiencing a loss in their life. And I've always kind of suspected that people who have difficulty coping with pain probably have difficulty coping in other areas too, and that we might be able to harness this to improve intervention. So although there hasn't been too much research here in pain, we know from the broader psychology literature, so if we zoom out from pain psychology and zoom out from rehab psychology and sort of take all of the field of psychology as a whole, again, there are hundreds, if not thousands of studies that show that people who struggle to regulate their emotions effectively are more likely to have poor mental health outcomes in numerous domains, and also to have poor physical health outcomes. So for example, measures like cardiovascular health. So for this reason, emotion regulation in general is a common target of psychology interventions, broadly speaking. So with that background, I'll just review a few questions that really drive my research program. So I'm very curious to understand how people with chronic pain regulate emotions in general. Again, this is not something that we know a lot about, but I'm curious how people are doing it and how this relates to long-term outcomes. And ultimately, my goal is to figure out how we can harness these principles of emotion regulation to improve pain treatment and expand what we're doing now by really focusing on pain coping. So I'm going to show you 3 areas of research that I've been working on over the last few years that get at these questions and that aim to lay this foundation of understanding the role of emotion regulation in pain. So first, I'll show you a theoretical review that my colleagues and I worked on describing emotion regulation in pain. Next, I'll show you findings from a meta-analysis where we honed in on one very specific aspect of emotion regulation in pain and how that relates to pain outcomes. And then finally, I'll show you data from a large longitudinal cohort study that my colleagues and I have been conducting over the last couple of years, where we've been able to test some of these theoretical questions empirically and start to parse the longitudinal relationship between emotion regulation and pain so we can see actually how does this matter and how is this impacting outcomes. All right, so I'll start here with this theoretical review on emotion regulation and pain, which was published a couple years ago in the American Psychologist. So the goal of this review, we wanted to bring this model of emotion regulation to chronic pain because again, this isn't something, emotion regulation has a very rich theoretical history in the general psychology literature, but that model hasn't really been pulled into chronic pain. So the first goal here was just to pull in that model to the field of pain and think about how the data that we have in pain relates to this broader emotion regulation model with the goal of really understanding what gaps there are in the literature. Another goal of this paper was to think about how emotion regulation might help us understand people who have both chronic pain and problematic opioid use. So I'm not going to spend as much time on that third point here, but I'll just give you some context that problematic opioid use is defined as any use other than what's prescribed. So a little bit more background on emotion regulation. So in the broader mental health, general psychology world, emotion regulation is recognized as a transdiagnostic factor. And what that means is difficulties with emotion regulation are thought to underlie a lot of different diagnoses, so transdiagnostic. So the mental health literature shows that difficulties with emotion regulation help explain depression, help explain anxiety, PTSD, and substance use. And this is important because if we have one thing that underlies many different diagnoses, then we can target that one thing in treatment and see improvement in many different domains. So the premise of this review that I'm going to show you was to extend this model to see, could emotion regulation also be a transdiagnostic factor that helps us understand chronic pain and problematic opioid use? So this is the model that we pulled in from the broader emotion regulation field and adapted for pain. So I'll walk you through this here. The first step in choosing to regulate emotion, so sort of on purpose deciding that you want to change how you feel, which is a lot of what we do in a psychology intervention. Emotion regulation can also happen sort of without conscious awareness, but here we're really focused on when you make the choice to change how you feel, which again is often what we're teaching people how to do in psychology interventions. The first step is just noticing how you feel, right? You have to recognize that there's something there that you want to change before you can do something about it. So the first step is recognizing what you feel. And then at that point, you can consider different types of strategies to select and implement to then try to change that feeling. And when you are changing your feeling or endeavoring to change your feeling, there's a few different things you could do. You could downregulate, meaning feel less of something, or you could upregulate, meaning, you feel more of something. And you can regulate your negative affect or negative emotion, and you can regulate your positive affect and positive emotion. So when we put those things together, there are four things that we could regulate. We could try to downregulate negative affect, which means feel less bad. That makes sense. We could try to upregulate positive affect, so feel more good. That also tends to make sense. A couple that might seem more counterintuitive, but I'll build a case for. You can also upregulate negative affect, so feel more of something bad, or downregulate positive affect, so feel less of something good. So this is what intentional, explicit emotion regulation looks like. Recognizing a feeling and then engaging in strategies to change how you feel in one direction or another. So I'm going to skip this first box, emotion identification. I'm going to take a deep dive into in the next study that I present. So for this part, I'm going to focus on strategy engagement. So what do we know about how people with pain are engaging in strategies to change how they feel? So we'll start with downregulating negative affect, feeling less bad. This one has by far received the most attention. This makes sense. We feel bad and we want to feel less of that. So I'll start by saying that people with chronic pain, it turns out, have elevated negative affect. So compared to the general population, we see higher levels of negative affect in this population. And again, if you work with people with chronic pain, this probably makes sense anecdotally. So a lot of research out there looking at how people with chronic pain try to reduce negative affect. And most of what's out there shows use of strategies that aren't all that effective in the long run. So pain catastrophizing, like we talked about, avoiding activities, avoiding scary things feels really good in the moment, but it tends to catch up with us with time. It doesn't resolve the underlying issue. And kind of to summarize what we found here, I pasted this graphic on the slide here. This is the fear avoidance model, which is a classic model in pain, and it helps explain why some people go on to develop pain and other people don't. So I'm just going to walk you all through this model because I think it kind of summarizes nicely what we know about downregulating negative affect. So if people experience pain either because of an injury, a surgery, or just an acute pain episode that has no clear underlying source, people feel pain. One way to respond to that pain is with a lot of fear or with pain catastrophizing. So assuming that pain means something really bad, assuming there are going to be very bad impacts on your life because of that pain, that can lead to a fear of movement. So managing that pain catastrophizing by just avoiding anything that might make the pain worse. This makes people really tuned in or hypervigilant to their pain, which again can cause them to avoid activities. This is where we sort of get into the all day on the couch scenario, all day in bed under the covers scenario, and as you all know or can imagine, this leads to physical deconditioning, it leads to greater disability, and all of this is also a perfect storm for depression. So really kind of disengaging from valued activities can lead to depression. And of course, all of those things together then leads to greater pain. So I'm not sure if you can see my mouse here or not, but this is a vicious cycle. And all of this kind of boils down to a failure to downregulate negative affect at each turn. And then just to show you sort of the path of recovery on the other end, some people might have pain. They have little or no fear about that pain, so they're able to confront the pain, go on with their life, and that promotes recovery or resolution, or just being able to live with the pain that lingers. So as I mentioned before, this is a common target of intervention. We see these strategies. So we see strategies for helping people downregulate negative affect in our pain psychology interventions. And just briefly, in the context of what we know about people who have both chronic pain and problematic opioid use, we see similar trends, maybe a little bit more pronounced, difficulties downregulating negative affect. And the other thing that we see that's just kind of interesting is that opioid use, when used as prescribed or not, has the effect of reducing negative affect. So this can become problematic for people who don't have other strategies to downregulate negative affect when they suddenly have something powerful that can do that. And that's not to say that applies to everybody or most people who take opioid medications, but once a dependency develops, this can be one of the things that maintains it. So moving on to our next intuitive category, upregulating positive affects, so feeling better, feeling more positive emotions. So there's been, over the past couple of decades, kind of mirroring trends in the broader psychology literature, there have been a number of strategies or short interventions to help improve positive affect. So a lot of the things, again, that we practiced in Anna Agranovich's wonderful presentation last week. So a loving kindness meditation is something that can increase positive affect. Other things that we tend to see in rehab and also in pain are benefit finding. So finding reasons why it's positive to have a chronic condition, downward comparison. So for some people, it can be helpful to think, well, this could be worse. I'm happy that it's not worse. That doesn't work for everybody, but it does help some people. And again, I'm sure folks have seen that anecdotally. Unfortunately, when you look at the impact of these positive psychology interventions in pain, we don't see robust effects. So far, we haven't really figured out how to harness this in intervention to have big effects for pain. But this is a new and burgeoning area of literature, so I expect we'll see more robust trials over the years. Just a quick note on people who have both chronic pain and problematic opioid use. We do see greater anhedonia, which just means less positive emotion overall. And we also see some evidence of altered natural reward processing, which just has implications for how positive emotion is experienced. Okay, so now we're moving into our counterintuitive categories here. Upregulating negative emotion, so feeling more of something bad. So it seems counterintuitive, but in fact, experiencing negative emotions is a really critical part of healing. And we know this from the broader psychology literature. So when we experience something traumatic or when we experience a loss, there's a normal process of negative emotions that come up. And when we see people try to push those emotions away, to avoid those emotions, it tends to stay kind of suppressed and can come, and it doesn't resolve. So this can lead to lasting problems. So like a metaphor that I use sometimes in treatments, it's having a Coke bottle that you're shaking up and there's all this fizziness, carbonation. And then when the cap opens, it can be kind of an explosion. And that's not how it works for a lot of people, but sometimes it does work that way. So all that to say that there is immense value in feeling negative emotions. And when people push those emotions away, that can cause problems. So what we know in pain is that emotional avoidance or suppression, so trying not to feel bad things, is very, very common. And there is growing evidence that interventions that help people experience that negative emotion can lead to healing. So for a long time, studies have looked at expressive writing in pain. So this is just essentially journaling, spending 10 minutes a day writing about the experience of living with pain. And this leads to some small but significant improvements in pain over time. This was sort of the first research that was showing us that really facing and experiencing and expressing emotions can be healing in pain and can lead to improved pain outcomes. One of my mentors, Mark Lumley, who's at Wayne State, developed emotional awareness and expression therapy. And this is a traditional 8 to 12 session psychotherapy program that at its core helps people recognize their emotions and learn how to express them to themselves and to other people. This intervention does a lot of kind of going back into the past and finding some of those sort of unresolved negative emotional experiences. So this treatment is new, but there have been probably 5 to 6 RCTs published to date. And we're finding that this emotional approach, which differs a lot from sort of more traditional pain psychology approaches, is leading to improved pain outcomes, improved mood outcomes. And every study that's included a CBT control has found that in many ways, this therapy is actually outperforming CBT. So these results from these clinical trials that are starting to crop up are showing us how important it is to help people experience those negative emotions. Not a lot done here on chronic pain and problematic opioid use. So I'll move on from there. So our second sort of counterintuitive category, feeling less positive emotion. Why would you want to feel less positive emotion? There are actually a lot of benefits or functions to this. You might think about interpersonally. If you've had a great day and you're talking to a partner or a colleague or even a patient who's in a state of really negative affect, then you'll downregulate your own positive affect to meet them where they are. Another kind of example is like not laughing at an inappropriate joke in a professional setting. So there's all kinds of reasons why you might actually want to feel a little bit less good or express a little bit less good in situations. Nothing really here in chronic pain, but some things that we speculated. We thought this might have a role in setting realistic expectations about physical activity. So we work with patients to set goals about what types of things they want to engage in over the next week before we see them again. And sometimes people set very lofty goals that aren't terribly realistic. And so this might be an opportunity where there's room to kind of down-regulate expectations a little bit. So just some thoughts there. So, all in all, just a few key takeaways from this work. We know a lot more about how people cope with pain than how they are engaging in general emotion regulation. So most of the data that I showed you related to how people cope with pain specifically. There are a lot of limitations to what we know about cultural and developmental factors that really define the success of emotion regulation. And I'll just pick on pain catastrophizing for a minute. In some cultures that have a more communal approach to regulating emotions, pain catastrophizing can actually be a very normative way to sort of express one's emotions and feelings to other people and then elicit help in regulating those emotions. So there's some concern that pain catastrophizing has really been pathologized through this Western lens. Similarly, developmentally, again, picking on pain catastrophizing might actually be a really normative way that little kids regulate their emotions because they don't have the awareness and the context that an adult has to sort of create more balanced statements. And again, they're relying on other people to help them regulate those feelings. So they're kind of, by expressing their fears, they're listing that help that they need. So there's a lot more that could be said about that, but I just want to kind of highlight that this literature is very limited in that way. This literature is largely cross-sectional. Very little research has looked at emotion regulation in pain. Basically, no longitudinal research has looked at emotion regulation in pain beyond pain coping. And one that I just want to highlight here that I think is really important is that negative emotions are not always bad. So some of our traditional models assume that the goal is always sort of to feel less bad about something. And hopefully I've convinced you that there's some value to experiencing negative emotions. And that has implications for the way that we treat things like pain in pain psychology.
Me that he's come back with is with the PT. It's with Amanda.
Okay. Oh, I thought it was you.
Eva, if you could mute, please.
Oh my God.
No problem. Thanks. Wouldn't be a Zoom grand rounds without someone typing up. No problem. Okay, so moving on. So one other small point that I'll make moving forward is I'm going to shift the nomenclature a little bit. And rather than pain coping, we'll focus on, I'll be using the nomenclature pain specific emotion regulation, and I'll be referring to general emotion regulation. And based on our review of the literature, I think this reflects the theory a little bit better. So we'll be using that moving forward. So I'm going to take a quick detour back to this emotion identification box. So we talked a good bit about how we talked about strategies in pain, and now we'll talk about emotion identification. So specifically, alexithymia, which is a specific deficit in emotion identification, I'll define for you later. This study conducted a meta-analysis looking at levels of alexithymia in pain. So again, going back to this emotion identification box, alexithymia refers to difficulties identifying and describing one's emotional state and a preference for externally oriented thinking. So we all vary in how aware we are of our emotions. Often when I introduce this concept to people, they say like, oh, I know someone who is really bad at this or really good at this. So this is a construct. It's a continuous construct. We all fall somewhere along the spectrum. And the goal of this paper was to see whether people with chronic pain have higher alexithymia compared to people who don't have chronic pain. We used, although alexithymia is continuous, we used a cutoff score for this. And then finally, we wanted to see among people who have chronic pain, is alexithymia associated with worse pain intensity, worse pain interference, worse depression, and worse anxiety. So I'll orient you to meta-analysis if this is a new methodology for you. So a meta-analysis is where you pull data from independent studies and analyze together to determine an overall effect. So like in a single study, you would have participants. In a meta-analysis, you have studies. And so you extract effect sizes from different studies, and then you're able to pull all of those findings together to make a strong statement about what the literature is saying. So we developed complex strategies to identify, search strategies to identify every paper that referenced alexithymia and any type of chronic pain. And we were looking for any study, any chronic pain condition where alexithymia was assessed. In our case, every study we found alexithymia was assessed with a particular questionnaire. So this is a Prisma diagram you see with meta-analyses. You can see here just that we basically identified about 1,200 studies, and we reviewed every abstract for potential eligibility. Then we reviewed full text, and we wound up with 75 studies that measured alexithymia in a chronic pain population. So then we were able to extract findings from each of these studies to draw some big conclusions. So the first aim was to understand whether alexithymia is higher in people with chronic pain versus control. So again, here we used a cutoff score. And this picture that you see with the lines and diamonds is a funnel chart. It's a way of visually depicting meta-analytic findings, and essentially each line here represents a study's mean and standard deviation. So when we pool the effects across all of these studies, we see that in fact, alexithymia is higher in chronic pain with a very large effect size. So alexithymia is much higher in people who have chronic pain compared to people who don't, which tells us that people with chronic pain are more likely to have difficulties describing their feelings. So the next question was, how does this matter clinically? So among people with chronic pain, is alexithymia related to worse outcomes? And so what we found, again, when we pulled correlation coefficients across every relevant study, we found that among people with chronic pain, alexithymia was associated with greater depression and anxiety. This effect was medium in magnitude, and greater pain intensity and interference. This effect was small in magnitude, but statistically significant. So overall, in pain, alexithymia is higher. So people have difficulties identifying and describing their emotions, and people who have this, who have more of this, are more likely to have poor outcomes. So this is important. This is a part of emotion regulation that is important, and that we may think about how to incorporate an intervention. All right, so now getting into some empirical data. So my colleagues and I over the past couple of years have been collecting data from a large group of patients with chronic pain across the United States to start to look at the longitudinal relationship between emotion regulation and pain. Again, this is something that we don't know a lot about, but we want to start to design rigorous longitudinal studies to be able to say that this difficulty with emotion regulation does or does not relate to this outcome with the goal of influencing treatment. So I'm going to show you results from one published paper published just recently this year in Journal of Pain, and then one paper that's not published yet, but you can see it's close enough that I can share a screenshot of the title page. So we're very close here. So this study is comprised of adults with chronic pain across the United States. We recruited these people through Amazon MTurk, which is a database of hundreds of thousands of research participants. We worked with a third-party company who helped us identify, screen people with chronic pain out of this large database, and also worked with them to achieve a sample that was demographically representative of the broader chronic pain population. So we were able to oversample groups that were underrepresented in our study in order to get a sample that was racially, ethnically, and gender representative. So that part was important. And we were able to recruit 1,453 people at baseline. Our first baseline assessment was April 2020. This was a very fortuitous time to have a large online study planned to launch. So that worked out well for us. And this database has also launched another series of papers where we're looking at the impact of COVID-19 on chronic pain. So I'm not talking about that today, but if you're interested, we have a couple papers published there and have been able to make some strong statements about the impact of COVID-19 on pain, because again, this study was just scheduled to launch in April 2020. So we also gathered follow-up data at 3 months, 12 months, and 24 months. This we just finished collecting. I'm not going to show data from this today, but I wanted to just call it out because it was thanks to a PM&R research seed grant that we were able to get that 2-year follow-up data. So I wanted to give a shout out to that mechanism and thank Preeti and her team for making that available to us. All right, so in this large, we administered a large survey to all of these participants at each of our 4 time points. And what we did were to include measures of pain-specific emotion regulation, so pain catastrophizing, pain acceptance. I think you're all familiar with that by now. And also a few measures of general emotion regulation. The selection of these measures were informed by our theoretical model. So here we have alexithymia, getting at emotion identification. And then we have emotion approach coping, which is a way of upregulating emotions. It's responding to emotions by processing them and experiencing them. We have reappraisal, which is the strategy of restructuring negative or catastrophic thoughts to be more neutral or realistic. And then suppression, which is that like trying to tamp them down to feel less of it. So we measured this at baseline, and then we measured pain severity and pain interference at 3-month follow-up. And our first question was, okay, how do pain catastrophizing and pain acceptance, these pain-specific emotion regulation measures, relate to outcomes? And we, replicating a lot of other literature, we found that greater pain acceptance was associated with less pain severity and less pain interference. We found greater pain catastrophizing was associated with greater pain interference. Not pain severity, that was a little strange, but in psychology, we were better at predicting disability, and pain interference is a measure of how much pain interferes with your life. It's a form of disability. We're better at predicting pain interference than we are at pain severity. So it wasn't too surprising. And then we wanted to see, okay, well, when we add these general emotion regulation factors to the model, what happens, what changes? So we found, first of all, we found that the association between pain catastrophizing and pain interference became non-significant. We think this is really important because a strong association between pain catastrophizing and pain interference is just a very, very robust finding in the literature that has been replicated over and over and over and over. And what we found here in our sample was that once you accounted for general emotion regulation, that relationship became non-significant. So again, these are initial findings, these are preliminary in need of replication, but it hints at the possibility that emotion regulation is tapping into something bigger, or more broader, more relevant, more transdiagnostic. Of the specific general emotion regulation factors, we only saw alexithymia as significantly predicting greater pain severity. So more alexithymia, more pain severity, more alexithymia, greater pain interference. I'll just make a note here that we used a rigorous type of statistical analysis for these findings. We controlled for absolutely everything that could have possibly influenced findings, including baseline pain severity and pain interference. So we're able to have a lot of confidence in these findings. Not to say that they're not in need of replication, but just to highlight that we're confident about these results in the current sample. So this first study, the main takeaways are that general emotion regulation contributes to pain above and beyond pain-specific emotion regulation. And it highlights the importance of assessing general emotion regulation alongside pain-specific emotion regulation when we're trying to predict pain outcomes, which of course is a very important question in the pain field. Okay, so study 2, here we're looking at 12-month outcomes. And this study was driven by a desire to understand how these different strategies cling together. So I've suspected for a while that people who have greater pain catastrophizing, as I said before, probably also catastrophize in other areas. So I thought once we sort of put all of these things together and we see what different profiles of emotion regulation look like, I thought that we might see that people who have high pain catastrophizing also have lower reappraisal as a general emotion regulation strategy. And I thought, people who are better at pain acceptance are also probably better at emotional approach coping. So I wanted to see how do different levels of pain-specific and general emotion regulation cling together, cluster together. So in order to look at this, we did a latent profile analysis to see how patterns of responses cluster together. So I'll walk you through that. Here you see the circles. I've introduced you to these constructs already. These are sort of overarching constructs. Many, these are all questionnaires. Many of them have subscales underneath them. And so that's not terribly important other than the squares represent different types of the circles. But what we did is we took all the squares and we ran a latent profile analysis, which shows us whether there are specific groups in our sample that have particular patterns of responses. So I'll show you sort of the visual LPA analysis because this is kind of cool, but then it's also complicated, so I'll walk you through it. Basically, our LPA analysis showed us that we had 4 distinct groups within our sample of 1,453 patients. And they could be categorized based on their responses to these questionnaires. So just for example, one group in red had high alexithymia, high suppression, and high pain catastrophizing, if you can see that on the chart. Another group in blue had low alexithymia, high emotional approach coping, and low pain catastrophizing. So this doesn't need to make sense, but just kind of visually show you what this type of analysis gives you. To synthesize all of this, our 4 groups can be described as people who have difficulties with general emotion regulation only. This captured about 1/3 of our sample, and these were people who had, for example, high alexithymia, high suppression, and low emotional approach. So not great ways to regulate emotion in general. And we didn't see evidence of difficulties with pain catastrophizing or pain acceptance. Our next most common group were people who had difficulties with both pain-specific and general emotion regulation. So here we see, again, some not the best ways to regulate emotion: high alexithymia, high suppression, low emotional approach. And we also see high pain catastrophizing and low chronic pain acceptance. The next most common group, about 1/4 of our sample, were skillful in both pain-specific and general emotion regulation domains. So these people were unlikely to, they were had low alexithymia, they were unlikely to use suppression, they had good emotional approach coping, and they also had low pain catastrophizing and high chronic pain acceptance. And then finally, the least common group were people who had difficulties with pain-specific emotion regulation only. So that's a lot, but a couple key takeaways here. So this is not what I was expecting to find. I didn't expect our groups to sort of split based on general emotion regulation versus pain-specific emotion regulation. I thought we would see trends across different types of strategies. Like I kind of said before, I thought maybe we would have a more expressive group that was high on emotional approach and high on chronic pain acceptance, but that's not what we found. The results from this study, again, a single study that needs replication, suggest that pain-specific emotion regulation and general emotion regulation may actually be independent. This has a lot of implications for intervention, because it might be that people who have, for example, difficulties with both pain-specific and general emotion regulation difficulties might benefit from traditional pain coping treatments that add on more general emotion regulation pieces. People who only have difficulties with pain-specific emotion regulation might benefit from just that traditional pain coping approach. And it may be that people who have just difficulties with emotion regulation in general, but not in pain, they might benefit from more mental health treatment that has a bigger focus on general emotion regulation. So a couple other takeaways here. Most people in our sample had difficulties with general emotion regulation. So I was excited to see this in the sense that it fits my story that emotion regulation is difficulties with general emotion regulation is super relevant for this population. So we're not just talking about problems managing the distress associated with pain. Here we're seeing problems regulating emotions in general. So we see a lot of alexithymia in this group. We see high suppression, so people just trying to push the emotions away, and that low emotional approach where they don't want to approach and feel the emotions. We talked about how this can lead to poor outcomes. About 25% were resilient with skillful emotion regulation in both domains. This mirrors the broader literature. That many people with pain are resilient and can cope with pain and other stressors in life just fine. Interesting that people who had only problems with pain-specific emotion regulation were the least representative, which is important because this is what our interventions are targeting. Okay, so the next question here was, now that we have these groups, how does this relate to 12-month outcomes? So 1 year later, people who fall into these groups at baseline, what does their pain look like in 1 year, and what does their depression and anxiety look like in 1 year? So what we were able to do, again, using robust SEM analysis, controlling for everything we could possibly control for, we were able to rank which groups had the worst outcomes. So I'm just going to summarize a few trends here. People who had challenges regulating both pain and general emotions had worse outcomes across the board. So these people, again, even controlling for baseline factors, membership to this group predicted worse pain severity at 1 year and worse pain interference at 1 year. So people who belong to this group were likely to deteriorate in these areas. Same with depression and anxiety. Interestingly, for pain outcomes, the other groups weren't differentiated on outcomes. So we see that people who had difficulties with either pain or general, or were skillful in both, were all the same when it came to pain severity and pain interference. It may be that skill in one domain protects against outcomes in pain severity and pain interference. For depression and anxiety, the pattern was a little bit different, where we saw people who were skillful in both had the best outcomes. So we see that protecting against depression and anxiety requires skill in both domains, which again has some implications for treatment. So that was a lot, and I think we've kind of already, I've kind of already summarized the main points here, but there's a lot that we can think about these findings for how we might think about treatment in the future. A number of limitations to this research that are important to note. As I continue to say, this is one sample. This has not been tested before. There's need of replication. This was all questionnaire based, and questionnaires that people completed at a single time point at 4 different times, but at a single time point. So what we really want to see for assessing emotion regulation is we want to be able to get a lot of assessments, for example, over the course of a day. So we see how emotion regulation unfolds. This is very resource intensive, but this is a future direction of this work. You could argue for different theoretically driven questionnaire batteries. Again, this is sort of a first step to get at this question. So in summary, difficulties with emotion regulation in general are common in chronic pain and lead to poor outcomes. And there may be benefit in expanding those traditional pain psychology treatments that really hone in on pain coping to expand to address general emotion regulation, pulling from what we know from the broader psychology field, particularly for people who have those difficulties. We may even be able to phenotype people based on their emotion regulation profile and tailor treatment in that way. Again, these are all many future directions that could come from this work. So just to highlight a few future directions that I'm currently working on, I didn't talk too much about it, but there are a lot of other problems with the way we assess emotion regulation in pain and in general. For example, the alexithymia measure that's commonly used has many limitations. So my colleagues and I are currently validating a new measure of alexithymia that's thought to be more psychometrically sound in the pain population. So we're excited to see, well, I can tell you it is more psychometrically sound. So we're excited to have a potentially better measure of alexithymia to put out there. As I said, intensive longitudinal sampling, which is just that getting repeat assessments over the course of the day. So I'm very interested, moving on, to how these models apply to relevant rehab populations. So I have a really strong interest in orthopedic trauma and understanding how emotion regulation plays out and predicts outcomes after a trauma, an orthopedic trauma, which is almost always very painful, and also is almost always very emotionally distressing. So we're doing a pilot study right now in orthopedic trauma at Hopkins to test these same models in this population and see how emotion regulation 6 weeks after a trauma predicts 6-month outcomes. So moving on, the long-term goal here is to use these study findings to inform intervention. So a couple of things my colleagues and I are working on. We're meta-analyzing the massive literature looking at depression and anxiety in pain. There's not a lot of consensus actually on how common different mental health disorders are in pain, although we know it's elevated. So we're synthesizing all of the literature so we can make some strong statements about what prevalence looks like across different populations. And then we can start to think about how we might help treat people who have both pain and depression or both pain and anxiety. And again, sort of considering emotion regulation as a potential transdiagnostic target. Finally, I have some pending grant funding to test a specific emotion-focused therapy for ortho trauma to see how that improves outcomes. So just some quick acknowledgements, not enough time to thank everybody, but I want to give a special thanks to my mentors, Steve Wegner here, Claudia Campbell in psychiatry, and Mark Lumley at Wayne State. And I have to thank my collaborators, Chung Jung Moon, who goes by Moon, who's at Arizona State. He's been instrumental helping get the large IMTRC study off the ground, and he's responsible for any fancy statistical analysis that I showed today. Fernand Rostu is not actually reflected on these specific studies I showed, but he is entirely responsible for launching every single future direction of this work. So I have to thank Fernand for supporting this work and really helping take it to the next level. Lakia in our own family has also helped with the IMTRC studies. Lakia McGill, Patrick Finan in psychiatry, and my friend Emma Fisher, who has taught me everything about meta-analyses. A few grants to thank here. And again, I want to give a special shout out to the PM&R Research Seed Grant, which funded the 2-year follow-up. So I'll just conclude with a picture here and say thank you. This beats any stock photo I could find of emotion regulation. This is my son looking at a picture of a book that says, "Look at the happy baby, can you make a happy face?" And he is clearly not making a happy face. So there's a lot that that babies have to learn about emotion regulation as well. So I will cut that off and welcome any questions that you all have.
Thank you, Rachel. It was a great talk, and hopefully you can hear me. Great presentation and very interesting data. I have, a question about. I'm just happily surprised, and I want to highlight that you use the Amazon Turk as a platform to launch a lot of these things. People in my group have been doing that for doing motor control studies and so on. So I'm amazed the flexibility of this platform. Is there any concern about that, like in terms of the type of patients that you get, like selection bias, because you are using that type of platform, and you get people who maybe are savvy in Amazon Turk, which I never heard before until somebody in a younger generation brought up to me and so on. Can you talk a little bit about those elements?
Yes. Thank you, Pablo. That's a great question and an important part of our methods. So So we worked with a couple things. We worked with a third-party company, which made this research expensive, whereas MTurk can be cheap. This was not cheap because we worked with a third-party company who helped put in a number of stops to ensure quality data. So through MTurk, people have a quality rating. So we only took people who had a very, very high quality rating. We had embedded in our survey attention checks. So people have to say, please select never true. And anyone who fails a single attention check is excluded from the database altogether. We also have other stops. So for example, people who we do pilot testing to figure out how long the survey can take, and people who complete it too quickly are excluded. And it's a pretty conservative cutoff, and people who take too long are excluded. So these are some of the strategies that we've put into place. There's some good validation studies now that show that MTurk data is as valid as in-person data, or in some cases even exceeds the validity of in-person data as long as you're applying these stops. So I would say it made it a little bit more complicated, but we were able to put some sort of practices in place to promote high quality. But that said, you never know what you're gonna get.
And in terms of age, is this? I mean, I presume you had that information. Are you just testing a younger group of the population?
So this is where we were able to use oversampling. So we did achieve, so we have a really good representation of age and of household income. So we have a good range of age, household income, and then we were able to demographically match on race, ethnicity, and gender. So when we compare this to studies that have looked at chronic pain in the general population, our sample looks very close to that. So we were able to recruit a sample that looks very similar, which is another reason why this wasn't a cheap way to do Amazon MTurk.
Sure. That's great.
Those are great questions. Thank you.
And these are challenges that people experience as we move science to test it online and
right.
mechanisms and so on. So, but fantastic.
Thank you. Yeah.
Very nice work. Thanks.
Very, very important methodological points. Thanks for bringing those up. I see Fanan and Steve, hands up and mic off. Oh, and Nicole, sorry, Nicole.
I'll let you
go ahead.
first.
Go ahead, Fanan. Go ahead, Fanan.
Hey. Well, first off, Dr. Aaron, Rachel, I wanted to thank you very much for the presentation. Great job. And I had some curiosity about one of the future directions that you proposed. One of the future directions you proposed was related to this emotion-focused therapy that you're interested in pursuing in the orthopedic trauma sample. And in the presentation, you noted that there were a number of different kinds of emotion regulation abilities that can be targeted, or multiple could be targeted at once. There's the pain specific and then more general. And I'm just curious, when it comes to the emotion focused therapy, is there any work published by the author out in Wayne State to demonstrate that it's maybe working on some of these specific mechanisms, these specific underlying emotion regulation processes? And if not, do you have any hypotheses on what particular it might be working on?
Yeah, that's a great question. Thanks, Fanan. So there are, I believe, planned mediation and moderation analyses out of these clinical trials to be able to look at that. Those, to my knowledge, have not been published yet, although I can say one interesting mediation finding that was published is they were able to look at changes in central sensitization. So in chronic pain, central sensitization is one reason that's thought to lead to chronic pain, particularly pain that doesn't have a clear biological source. It just has to do with sort of overly sensitive pain processing in the body. And those types of pain conditions are thought to be particularly responsive to these more emotion-focused treatments. And so they have been able to show that improvements in the treatment overall are in part attributed to improvements in central pain processing. So it speaks to the sort of more biological mechanism of how psychological treatments, especially emotion-focused treatments, are helping with pain.
Thank you.
Nicole?
I was going to actually kick it over to David, who has his hand raised. He's a physical therapist. Let a different discipline get in.
Thanks. This was great, by the way. So thanks so much for presenting this. Especially with your last comment about central sensitization, I was super curious about how we could maybe screen for this with patients that we think would benefit from this. The one thought that's coming to mind is I struggle sometimes when maybe I'm picking this up because I don't want to sound like, I feel like it can kind of be a sensitive thing to question someone's emotional regulation. So I'm just thinking all these thoughts in my head about how we could get them help and make them feel safe in the process and not like confronted, for lack of better words.
That's a really, really good point, David. Thank you for bringing that up, especially as we think about kind of phenotyping, and these things can be very stigmatizing, right?
Yeah,
No one,
yeah.
and in fact, there's a movement in the broader pain psychology field to move away from the term pain catastrophizing, because patients, there have been studies, qualitative studies that show that patients can find that very invalidating. And so I think certainly this work is really at the beginning stages, and I think the long-term goal is to sort of personalize treatment. But I think best approaches in terms of, when we see a patient in distress and we know they need help in some kind of way, I think normalization is the best approach. So just explaining that living with pain is really hard for anybody, and that there are some strategies that might be available to help them learn how to live with pain a little bit better. So just really normalizing the distress and normalizing getting some help. And, in our department, I think it's always helpful to emphasize the interdisciplinary nature of how we treat pain. So, depending on the patient, maybe pulling on the science to say, research shows that your best shot at improving pain is targeting it from all the different angles, right? So you've got your medical approaches, and you've got your physical therapy approaches, and you've got your psychological approaches. And that's really how we see the biggest bang for our buck when it comes to learning how to live with pain.
Okay, thank you.
Thanks, David. Great question. Steve.
Just very quickly, I think just more broadly, Rachel, obviously it was a wonderful presentation and very nicely done, great graphics. One thing I want to bring attention to is what Rachel is doing here is reminding us of something that we forgot, right? We got psychology, everyone's very focused on emotion and talking about emotion and everything. And then we got all focused on cognitive factors and behavioral factors. And the emotion got lost. And what Rachel is doing is saying, hey, this thing that was really important before, we kind of got lost. Let's bring that back. And I think this is, we think about advancing research in any area. Sometimes a good thing to do is to say, what have we left behind that we need to maybe bring forward to explain variance, right? Because what's happening is the cognitive factors, the behavioral factors, the variance they explain is not large. But by adding emotional factors in, we account for more variance. And I think the fact, Rachel, you reminded us of what we forgot and reintegrate that is brilliant. And that's often is a way forward, right? Is remembering what we forgot. Thank you very much. Really appreciate this kind of presentation.
That's a helpful point. Thank you, Steve. All right, I see it's 1 o'clock. Thank you all. I'm always happy to talk about this more. So please let me know if you have other questions. And yeah, thank you all for being here. Hope you have a good day.